Gupta is here with us tonight to share some important information for healthcare providers about COVID-19. He's going to give a brief PowerPoint presentation followed by a Q&A session. You will be notified when the Q&A session begins. To participate, click the question mark icon on the bottom left-hand corner of your screen, or follow the prompts to ask a question if you are participating by phone only. Out of respect for Dr. Gupta's schedule, we ask that you use the Q&A session to ask questions rather than to vent. If we don't get to your question tonight, feel free to email it to the Onondaga County Medical Society, oncms@oncms.org, and we will follow up with Dr. Gupta. We'll post this webinar on our website and email a link to all of our contacts. If you're a member of OCMS and are already signed up to receive our emails, please be sure to check your spam folder. We send out updates every day. If you want to be added to our mailing list, email oncms@oncms.org, and we will add you to our listserv. And of course, if you want to join the Medical Society, please email us and we'll contact you right away. Dr. Gupta, thank you so much for your time, and please begin your presentation.
Good evening, everyone. Thank you for joining in. And it's really important and very trying time in our community, and I truly appreciate those who have joined. Hopefully this will be an informational session, will be helpful to you. I'm here joined with my medical director, Dr. Kwok-Win, also, who many of you probably interact on a daily basis, not throughout the year for different reasons. And I will just give you a very brief presentation to give you an overview what is happening at the local level, and it's not academic exercise here. We're just trying to be going into the very real work here. So I need your help in making this crisis pretty much go to the other side, and we can go back to normal. I don't have any conflict of interest. The intent of this webinar is to basically present how the public health system works. Public health system means all of you are part of the public health system. That also includes health system, primary care providers, specialists, emergency management with the different county agencies, state and federal agencies. That's what the public health system is. So all of you know it this time. Just to give a very, very brief reminder that coronavirus is not new. First identified in mid-1960s, named because it had beautiful crowns. You can see that picture looks so wonderful. There are four main subgroups: alpha, beta, gamma, and delta, and there are 7 coronavirus that can infect people. One of those things which we have seen in this, that it can jump from animal to human like some of the other viruses too, and hence the name when we call about novel coronavirus. This one is specifically called SARS-CoV-2. Just to remind all of you that the common human coronavirus are pretty much found in common cold. Some of them are listed here. I'm not going to go into each one of them. The one which we have been very concerned.
Dr. Gupta?
Yes.
I'm sorry, I'm just getting some feedback from folks that we might not be able to hear you, so
okay.
It seems like folks on the computer might be having some problems. I'm gonna Sandy, can you unmute everyone real quick, just we can do a quick check and hear. Is anyone having trouble hearing? No.
Yeah.
Good. Great.
No.
Perfect.
No.
All right. Thank you so much.
No.
We're going to mute everyone again.
The computer is not.
Can I go, or can I continue?
Go, Dr. Gupta. It's good.
Okay. So just to go over that, the one which are the serious ones is the MERS-CoV, SARS-CoV, and then SARS-CoV-2 now. I think we all are familiar with that. The reason I wanted to bring that out, there has been confusion in the community, and many of your patients might be calling you, oh, we went to the emergency room, they did the viral panel, and they said, oh, we have coronavirus. I know some of the patients I have gotten called, even on call, is we have a COVID-19. They go to the they even go to the media and say we have a COVID, we have a COVID-19, and that was not the case, because they were told they have human coronavirus. Out of those listed in this slide. So just to remind everyone. Just to give you evolution of the current outbreak, December, how many people thought about that what is happening in the China across the globe is going to be really coming and really change our life here in March. Just to give you timeline, January 30th, WHO declared public health emergency. 31st, here, Human and Health Services declared emergency, and 31st, the president pretty much put the travel ban. Everything happened pretty fast because now the cases were exploded. February 1st, New York State Department of Health signed a declaration of novel coronavirus as a public health threat to the New York State resident and is a reportable disease. February 11th, WHO officially named the disease as at COVID-19, and pandemic was also defined short, I think in February, I don't remember the date, which was the pandemic was a few weeks ago. So just wanted to give you some highlights of that. You might have gone through that Johns Hopkins website, which is linked at the bottom of the slide, and you can just do Johns Hopkins Global Health GIS map, and it will take you to this. I would ask all of you, if you are not seeing it, it's a really wonderful website to keep track of what is happening, not only globally, but if you can see from overall, this is a screenshot of that. This was from last night. That would have changed by this time probably. If you can see, that was 10:49:32 p.m. last night. There are almost nearly 400,000 cases, 16,000 deaths. That more than 100,000 people recovered. If you go to the left one, there you have the U.S. 43,000. And then if I go into the next slide, it's by the time I went, it was 46,000 right here. So you can see that how it looks like one of the AT&T advertisement or Verizon advertisement. It's light up everywhere. Not that we want to see that. The point is that New York is the one of the hotbed. Could it be that we have more cases? Yes, because we have so many travelers also, but then we have a large population. The question is that California is another hotbed, but we have a lot of testing capacity. That's what I can see at this point. So we are testing a lot.
I'm watching this.
Hello? Can you hear me okay, Sandy? Hello?
Yeah.
I can hear you, Dr. Gupta.
Okay. You can hear? Okay.
We can hear you. Everybody has to mute.
Thank you.
So New York State, this is the same thing, the same website. You keep on going from one, so you can see that how many cases are in New York State. New York State does not have typically which it owns, so I took it from the same website. And we also have created something for our Onondaga County. This is going through each towns. That's what we are trying to highlight, that it is in our community. So people who live in different places, they really should be cognizant of that, that it's not there or here. It's here actually. It's not in Westchester County. It's not in Seattle. It's right here. So we update it once a day, and that will be around 3 o'clock. That's what we did, updated. So this is from last night. We have 60, but we have since then we are getting more and more. So we will update that tomorrow. The problem is not going to go away. And I want you to stay tuned and look at these information. And this is actually at our website. If you go to our website and COVID-19 page, there is an icon there. You click on it, and you have a lot of not only other information, but the map is there. So this is more informational. So the few facts which you already know, I'm just going through, not presuming anything. Transmission, direct contact with secretion and large droplets. Incubation period, you all have heard 2 to 14 days, average of 5 days. Clinical features can vary from asymptomatic to upper respiratory tract infection, lower respiratory tract infection, GI symptoms, pneumonia, ARDS, and ultimately people die. We had our first death reported today in our community. So outcomes, 80% have mild symptoms, will recover, 15% have severe symptoms, 5% have critical symptoms. That sort of things we are seeing in our cases also. Some other facts, even though the travel history is used to be very important until a few weeks ago, it still sort of has some relevance from the epidemiological point of view, from us to see where people are coming from Europe, China, or from other countries which are then travel ban, or across the country, essentially domestic travel also, including New York City or California or some other hotbeds. Now we can be considered hotbeds in near future, seems like. So what you assessment, severity of symptoms of cough, shortness of breath, all these are very non-specific symptoms. You know, these people are presenting as like a flu-like symptoms. And it becomes, that's what it creates a dilemma. I think the initial confusion based on the guidance was the travel, which was the right thing to do at that time because we didn't have any community transmission. Since then, things have changed. We have a community transmission now. We have several cases which have no connectivity to the travel. It just happened, they are here. Some of those initial guidelines, whether it's a CDC or the New York State came out, they have continued to evolve and change. So right now, a lot of burden has come into pretty much to your doorsteps, which you are, whether it's a primary care provider, you are in a hospital, whether you're emergency room, pediatrician, OBGYN, you are hearing your patients are calling you and making that judgment call that patient needs to be tested or not tested. We did get a lot of phone calls in the beginning when they were very strict criteria because I think that at that time CDC thought that, oh, we can control a lot of those things, and so did New York State, so did we. I mean, everything is pretty much evolving at this point. At this point, it's here, so we are going to treat, we are pretty much taking it the way we will do the flu, essentially. You just go through the signs and symptoms. You should ask the travel history, but at the same time, take the consideration of underlying risk factor, which are the most crucial, because you really want to prioritize testing for those, because they need your most attention, they need our most attention. Because people deteriorate pretty fast in this one. And also, if somebody has like a pneumococcal pneumonia versus influenza versus a COVID-19, in those situations you can provide the treatment versus in COVID-19 you have only supportive treatment unless you are in an academic institution where you might be under those NIH studies which are participating in the new sort of a trial. So at this point we are dealing with what we have and we are doing our best. And then the various test sites are at this point. Many physicians have been very creative, and I really want to thank them. They have done their mini drive-through sort of thing. This is very innovative. That's very thoughtful. I think that's why we are able to get more people. We have a drive-through with the Syracuse Community Health Center, which we have worked with all the hospitals to staff that, and the Community Health Center and the county. Then emergency room, when people are sick, they certainly are going. Alertness and awareness in the community, emergency room that makes sure they are protecting themselves when they are going. Most of it, the surge site which we created, or triage site, was created out of the really necessity at that time because the ER, especially the upstate, was getting hammered. And because they had the viral panel, I think other places didn't have the viral panel, so it created a lot of bottlenecking there. And the triage site was pretty much opened. I think it has been about more than its second week now, and there has been a few thousand tests has been done actually. And there are, depending on where you have the test done, there are more laboratories are approved by New York State Department of Health. So initially, the CDC was controlling, so only, and even the New York State Department of Health's Wadsworth lab, which is a state lab, was not able to do that. That's why there was a lot of approval process was in the beginning. Then there were more, then the New York State Department of Health's website, the Wadsworth lab was approved, so we started to send it. Still approval was a little tedious. Then, with the demand, when you started to see the cases, again, now we are just behind in terms of, lab testing at that time, initial phases, that the more commercial labs started to come into the picture. Governor actually opened up more for like 28 labs were approved. There more are going through right now, seems like. And turnaround time has been quite a bit of complicated issue. Unless there is urgency, it's not like a quote-unquote stat lab you should do that you will get it in an hour or two. The best stat at this point, at least in central New York in Onondaga County, will be 24 hours. because we send it expedited in healthcare worker or somewhere, emergency professional, when we think there is a need to check it out because there could be more people might have been exposed. So we go by case, essentially. Otherwise, depending on the labs, it's 24 hours, 72 hours, and in some situation, unfortunately, especially from the triage side, has been like more than a week because of the way they were sending the test out to their out of state, which was one of them in California, it seems like. They had a lot of backlog. Then they started sending to Pittsburgh. Their turnaround time is much better. We have gotten actually in 2 days or 1 day even in some cases. So things are getting a little bit better, but still there is a lot of things to be done. So some of those things I wanted to go over is when the test is done, when you're ordering a test, the clarity in terms of that, if the person is sick enough and is concerned enough and you are concerned enough to have them go for testing, you really have to tell them that they need to self-quarantine until you tell them that their test is negative. Unless proved wise, you should presume that test is positive because the heightened awareness were there. Otherwise, why would you do the test? Because if these people are contagious, they are going to infect somebody else, especially those in their families, the vulnerable people, you know, the people who have immunocompromised status, their parents, grandparents with the diabetes, heart disease, and lung disease. You know the list. So I'm pretty much preaching to the choir, but I'm just reminding it's very important that when the test is ordered, it's serious. It's not something that they go out and go, hey, I'm going to get the test done. I'm going to go back when shopping, and I'm going to do that. They really need to have that mindset. They are going to protect, not only take care of themselves, but they have responsibility to the society. That is so important. And I want my colleagues, all of you, to really partner with me to communicate that message, because you are my voice. I think that's what I'm asking you, and that's what when I talk to Medical Society, do this webinar. It's not an academic exercise. This is a public health exercise right now. I cannot do anything without your help. So I want to feel comfortable that you are all in it with us. So this was considered like they are doing and waiting. Then when we get the tests, and then another category is the voluntary quarantine for the travelers when they are coming from those countries which are in level 3. If you go to the CDC's website, there are wonderful information. I hope you are going through that because we cannot cover everything in this 1 hour. I know that. I would really request all of you to visit CDC website every single day and make sure that you get all the information for the health professionals and then get the stats, so it just makes it easier for everybody. So the travelers who are returning from there, they are going to be asked for the voluntary quarantine. I think I put the little bit typo here, voluntary isolation. It should be quarantine. The quarantine is different than isolation. You all know that. I'm just going to go to semantics so that we are on the same page. So the travelers who are coming from those countries, they're supposed to be 14 days. Voluntary quarantine, we ask them to quarantine because they might have symptoms in those time frame and they might spread that disease to the community. The same is applicable to those people who are being tested. The other nomenclature is if you have a case diagnosed. Now, if you have a COVID-19, we get the test result positive. We want our primary care providers to work with us. We want them to inform the patient because you are the first line of defense. You are their caretaker. They relate with you, and they want to hear your voice of compassion, and you're going to be there for them. And at the same time, we are going to be there for them. Our role is a little different than yours. One of the biggest requests, since the office capacity of yours is decreased at this point in terms of one-on-one visits, that's something it's not recommended this one, but I would really strongly recommend and request actually that you stay connected with your patient, with your COVID positive patient, with the tele or telephone. Make sure check on them, especially those who are actually vulnerable, because you might find some things because you know those patients, what their basic baseline status is. And there's something called in medicine when I used to do primary care, and I'm internist, traditional internist by training. So there's something, if your patients don't feel good and you can relate with them, you can have them connected with 911 and then also have them hospitalized. Early detection of deteriorating situation is important. We are also there. We connect with them. We do contact investigation, and we work with you. So we are partner in it, and we want you to feel like we are in it as a team. We are not two separate entities. It's not that you signed off to us or we signed off to you. When I'm asking you to be part of our team. We are there to work with you because then we can provide the best care to our patient. So these people will, the cases, which we call cases, will be in mandatory isolation. Now that's the word I am not using lightly. They are going to be confined to their house. They get a commissioner order which I have to sign, and we deliver it to their house. For different means, we also ask them if they have any needs, and then we thermometer, different kind of things, whatever we can provide. If they have needs for food and they don't have any family member who can deliver it to them from the outside premises, nobody is going inside other than the people who are in household. So that is very important part for you to work with us and at least be aware of that. That's what we are doing it. And we also remind them for the temperature check twice a day. Whatever prescription medication they need to continue, that you are going to continue to work with them. The second term is, another term is mandatory quarantine for the household contacts who are in close proximity. Anybody who is COVID positive, anybody who has been in contact with them, whether they live within their household or they live outside anywhere, friend circle, they had dinner with them, they were referee in a game, or I'm just kind of think of it, if they work somewhere, these, depending on the history we get, we actually will advise that you are the close contact, so you are going to be quarantined, and they will get also commissioner's order until we say they are off, essentially. That's how the nomenclature works. So when you hear different things, voluntary quarantine is very different. We want people to abide by it because that really will reduce the transmission of virus, because that will comply with the social distancing public health policy, while the mandatory isolation and quarantine, and now it's official order, it's enforceable. That's could be misdemeanor. I mean, that's something nobody, I mean, we don't try to go that way, but we are asking people to comply with that. And you as our partner, you want to understand that lingo, so when your patients are calling and when you are going through some, what is this here? I just wanted to make sure you have that understand. And these things are so crucial because, as you know, there's no treatment of disease time. So what do we do? I'm not going to go everything. I already went through that, what mandatory isolation and those definitions of means quarantine. That's right here. We do surveillance, every data. When we give you the cases, you know, there were 2 cases, then it became 15 cases, then it became 60 cases. There'll be more tomorrow. So surveillance is important. We try to do linking to each other cases. We link to the household. Now we have a lot of spring breakers are coming back, young people. I mean, very irresponsible behavior, some of them showing. And that's okay because they're putting their parents, grandparents' life in jeopardy, especially if they have underlying disease. And we start to see the spike in those young ones who are returning to the community. So please spread the word that they really need to make sure that they are social distancing. They don't need to party out. They are on online schooling. Doesn't mean they are like 10 of them congregating and sharing their things and sharing their disease and really spreading in the community. So this is what I have. Sandy, did you say something to me? Hello?
No, Dr. Gupta, I didn't say anything.
Okay, all right. I'm almost at the end of it. So the other public health response is mitigation. Without going into too much, I think this is the public health departments do, mitigation, because infection is very disruptive to daily lives. And what we want to do is we want to reduce the transmission. We are reaching out, that's the county executive does, with our different departments, with emergency management. We have Department of Social Services. We look for the needs of the community in terms of trying to have their nutrition needs, daycare, and needs of the healthcare workers also. Whatever needs to be done, there is a lot. I put a lot of information. We have activated the Emergency Operations Center in the Civic Center. We are working with 911, EMS, emergency departments, daycare, I mean everything, seniors, all the community-based organization, you name it, we have to work it together. And I think that's important for all of you to recognize. The final thing is public health response is right now, the only tool we have is us. Public health tool is prevention at this point because no vaccine, no treatment, other than what are going to be the NIH trials. So non-pharmacological intervention we call, personal protective measures. Please make sure you disseminate that. You know that already, personal protective measures, hand washing and all these things. This is the same thing which we talk about flu. Community non-pharmacological interventions are very social distancing, school closures, and all these things are so important in disruption of this path of this virus that we really need to make sure that we personally are following it and our loved ones are following it and our workplace is following it. And that's how we can pretty much disrupt. Environmental sanitation is very important, cleaning and all those things. So we talk about the flatten the curve. This is from MMWR 2017, based on 2009 H1N1. If you look at that, you know, if you don't do anything, it just goes to the peak here and the health system collapses. That's what happened in Italy, and that's what we were trying not to have that. So our health, all the health system are working together to see, can we try to do this flatten the curve essentially? So all the health system can withstand that and we don't have that crisis and we can take care of the people who might need ICU care, hospitalization, whatever needs to be taken care of that to reduce the mortality and impact of that. At the same time, transmission of infection. So it's a joint venture. I would say this is joint venture because we all are in it there together. This is more of a just a hypothetically looking at that, you know. Every sick patient transmits infection and we have to break it, and we really need to have aggressive public health measure. We can only do it together if we flatten the curve. So that's what my few you know, thoughts. And we put this here. This is the social distancing thing. I'll be happy to take any questions, and with Dr. Wynn, my medical director.
Wow, thanks, Dr.
To ask your question, please press *6.
Okay, Dr. Monica Jones, what's
Hi.
your question for Dr. Gupta?
I don't know if she can answer this, but we've been testing kids in our office because thankfully we have some PPE, enough PPE to do this right now. We're actually running out of viral transport medium and swabs. Is there any suggestions about who we can reach out to get that? Because our lab is apparently limited on what they have.
So which lab do you have?
LACNY? Laboratory line.
To provide you the what we call kits nowadays. That's kind of crude term.
Yeah, they're telling us that they're out.
So because what is happening, I mean, sorry, I'm getting the echo. Can you hear me?
Yes.
Okay, I don't know why I'm getting.
Oh, I'm getting an echo too.
Yeah, I'm just trying to get. How can we?
Do you want to try muting me for a minute and see if that helps it while you answer?
I will. I'm going to mute you. Dr. Gupta? Uh-oh, lost Dr. Gupta.
No, I'm here.
Okay, Dr. Gupta.
Okay, we'll have to bear with it, I suppose. Oh my goodness. So, can you hear me?
Yes, I can hear you now.
Okay, there's no echo now, right?
No, I think if I put the person on mute, it helps.
Right. Okay. So I'm just going to try to this here. No. I think I have to do just fine because I picked up the speakerphone. So I'm going to just talk. Can you hear me? Okay.
Yeah, it's good now.
Okay. So what I would say that we have the transport medium. We don't have it. We are able to secure few, but they are based on which labs they go. I certainly can talk to emergency management. What I would like to all of you to put a request to a number called, I'll give you the number, 315-435-2525. This is the emergency management request number, and you can specify it's a LACNY lab or different thing. We could try to also work with that. But then the question will come if there is a transport media for the Quest, how does it? The transport media is the same. Excuse me. I think, why don't you just send the request to that one, and then I'll talk to our emergency management commissioner to see.
Okay, perfect. Thank you.
That. Okay.
Okay. Okay, Dr. Oh, just a moment. Dr. Mariam Malar, what's your question for Dr. Gupta?
Hi, Dr. Gupta. Thank you for doing this. So my question is, there seems to be some confusion as to as far as elderly patients at risk, what is the age? Is it 60 or 65 that just because of age that there are increased risks from this virus?
So, I mean, 60, it has been said 60. Oh, sorry.
I can't hear you.
Can you hear me? Hello? Hello?
Okay, go ahead, Dr. Gupta.
Can you hear me?
Yes.
So 60 is okay. I mean, 60 considered elderly, but then 65, not elderly, sorry. There are lots of people probably at 60 years of age and feel like, really, you just called me elderly? 65, 60, 65, it's arbitrary. A lot of it is we have people under 40 who have underlying health problems. They really having severe consequences of that. So age is an important factor, as you will do it in any way, whether you say 60, 65. I think we are making some arbitration at this point. I would not focus a lot in it, rather age certainly, so 60, whether you put, I would take 60 actually, because people with 60 sometimes do have some other underlying health issues there, and we want them to be very careful about things. A lot of times this casualness has been there. Oh, if we get it, we'll be fine. We don't have anything. But one thing leads to another one. A lot of strong focus should be for your diabetics, your chronic COPD, people who have heart disease, people who have gone through cancer treatment, immunosuppression, and all those things. So anything which you will consider high-risk patient for flu, that's what I would consider that high-risk patient here, in addition to when you talk about age also. I don't know, Dr. Wynn, you have to have anything?
Pregnancy.
Oh, pregnancy.
Yeah.
Yes, pregnancy.
Okay.
Did that answer your question? I hope I did.
Yes, thank you.
Okay.
Sorry. Oh, my goodness. I have no idea how.
Dr. Jeffrey Kahn, what's your question for Dr. Gupta?
First of all, Dr. Gupta, thank you for everything that you and your department are doing. My question is that many of us have family members in the New York City area who are being told to stay home from work or who are being furloughed from work, and they are asking family members here in Onondaga County whether they can come home until this health crisis is over and it's safe for them to return to their usual jobs and life. My question for you is, if those individuals are currently asymptomatic, but we don't honestly know if they're infected, what would be the appropriate protocol before telling family members it's safe to come back to Onondaga County?
So, it's a tough question. It's because there's no specific guidance for domestic travel. However, there has been quite a bit that try not to, non-essential travels try not to, people are asking any non-essential travels should not happen within a week. Hello?
Oh,
Are you there?
sorry about that. Hold on just a moment. Restart it.
Hello?
Hello?
Can you hear me? Did the session is over?
Uh-oh.
Is it? Okay.
Go ahead, Dr. Gupta.
Okay, can you hear me now?
Yeah. Dr. Gupta?
No. You can't say anything. I can hear you. Yeah. Right. Yeah. So the main thing I think at this point is there is no like a written what you call order by the governor not to do these things. However, there has been continuous discussion about how to reduce the transmission from one community to another one. We have many people who actually came from New York City who were asymptomatic. I mean, I don't want to say many people, but decent number of people, when they're coming from out from the community, they are becoming symptomatic later on and had become cases. And same could be true for our county now. I would think that at some point in time. So what kind of official guide? I cannot give you any official guidance, but I'm giving you public health guidance, making a good judgment that if people do least amount of travel and stay where they are, I think it reduces the possibility of transmission, because when we travel, we do rest stop, different things. Everything actually is a touch point, unfortunately. And so much is not known about this virus that we kind of trying to take this approach. What you have seen, whether you look at, South Korea, how they were successful, or Hong Kong or some places, that social distancing and having the least amount of travel, which might be hard for the families, and I definitely understand that. If people have their own support system there, probably it will be better. If I had my family member, my kids are in different places, I'm telling them stay there, and that's okay. That's fine. And as long as you're doing social distancing with everybody, you're checking on them with the FaceTime and everything, and providing social support, it's good for everybody, because it's not transmitted by any at this point like any other airborne or anything at this point, not that we know of at this point. Especially if your relatives are elderly and they are pretty much secured in their place, that should be okay, as long as they can their support system in terms of the groceries and different things. That will be my best advice. It's not perfect, but I think we are asking everybody to think what we call social responsibility in making the judgment call for their loved one to go from one place to another one, because it takes all of us to turn the tide and going to flatten the curve.
Okay, Dr. Gupta. Hi, you're on with Dr. Gupta. What's your question? Hi, what's your question for Dr. Gupta?
Oh,
hello?
Hi.
Yeah.
Hello, can you hear me? This is Dominic Facciapani. I'm a second-year medical student at SUNY Upstate, and I'm the OCMS student representative for our class, for our school and for our class. We have a question regarding the status of medical student involvement in the hospital, not only for the current clinical third-year students, but also for the second-year students eventually transitioning into third year and into the hospital. Currently, the AAMC has advised against student involvement, and Upstate, like many other programs, have kind of disbanded the students from the hospital. And I'm not sure if you saw this, but Governor Cuomo last week reportedly sent out some sort of survey to Albert Einstein, indicating or having a questionnaire indicating their level of interest for students to help out in the hospital more if they're needed. So I was just wondering if you have a position on this, and if you have any information as to what might happen in the next few months.
I'm asking our medical director. I do not have an answer. Sorry, I'm just going to put this here. And for the Upstate, I don't know what their policy has been. That's something I do not know. Most of it comes from HGME and different other from, I don't know actually, so I cannot comment on anything. I'm asking Dr. Wynn if he knows anything. My medical director. Hang on.
I think there is a fine balance between a good educational period for young people in medicine versus the risk to them, because hospital is really a hotbed of nosocomial infections, and I think that when the hospital is cutting down elective surgery and go to the war footing, like our colleagues from Upstate States, they may not really have the the good time and supervision that ideally suited to protect our young, future colleagues. So I think it's like a fine walking, balance, almost like you limit all the visits of children when it's a big source for for family love and relief for parents in the hospital, and we have to do it sometimes. So hopefully, like Dr. Gupta and all of us believe in that. It's almost a form of social distancing, and I feel for you, but that's how we have to act nowadays.
Okay, is that all?
Yes, thank you.
Okay, thank you. Dr. Gupta,
Hello, I lost you, Sandy.
I have a question from Dr. Jeff Snyder. He wants to know, oh, sorry. Can you hear me?
I can hear you.
Okay. I have a question from Dr. Jeff Snyder. He wants to know, is the county creating a location, such as a hotel, the war memorial, etc., so that patients with mild disease do not go home and spread the disease to their families?
The county is working with all the hospitals in terms of, they have worked with the, when I said they have, we all have worked with all the institutions to make sure there's enough beds available. That's how they canceled all the elective surgeries, and to make sure that you have enough ventilators, you have enough ICU beds. For the mild one, at this point, they're able to accommodate. Yes, the county is actually looking for additional space, additional ventilators. County executive has been very open about these things. There's pretty much a daily dialogue is going on, and also looking for how we. Hello?
Go ahead, continue.
Can you hear me?
Yeah.
Okay, I think, did I lose you, Sandy?
Nope, I'm here. Go ahead.
Okay. So yes, these are all to Dr. Snyder's response. I will have is, yes, this is all work in progress, but in terms of whether it will be for mild illnesses, that will be to be determined depending on how the situation is. One of the questions I think raises, if there's no capacity in downstate, would they send the patients here? So a lot of these conversations are happening in our community, and then we pretty much have to work together everywhere. So right now, there is, I don't want to call it and jinx it, that it's enough space at this point. However, there is we are looking into the area where that can be further, like what we call surge capacity. And I think the location will be probably is being looked at it, and will be discussed and maybe disclosed in the near future.
Okay. Hi, what's your question for Dr. Gupta?
So I have a question that are they all recommending just doing the televisit? Because sometimes it's very, very hard to diagnose the situations just by televisit. So are we all converting that to it, or can we still bring the patients in the office if they don't have any other symptoms, any symptoms of concern with the coronavirus?
So I'll start, then I'll have Dr. Wynn add to that. Can you hear me okay?
Uh-huh.
Okay. So mostly, that's why the pre-screening over the phone is so crucial, that people just don't walk into the office. I was talking to one of the other physicians. They should not do that. You don't have to lock your office, that people kind of barge into your office. It's not an ER. They shouldn't do that to ER also. So pre-screening on the phone for every patient a day before, or a few days before, at least a day before, and even in the morning of, you should be doing it. If they have any cough, fever, any flu-like symptoms, they should not be coming to the office. The patient needs to be seen, so you can make a judgment call who you should be doing the televisit visit, who you can put off for a little bit, and routine hypertension visit, routine diabetes visits, few of those things if you can manage over the phone or tele, that will be really good for especially your elderly patients. Those who you think should be seen, you make the judgment call based on what you found out in terms of their travel, fever, anything, possible exposure. All these things are important in terms of your history taking initially, that pre-screening, and then you can have them come on a case-by-case basis. It's a little tough, but our lives have changed. This is not the same as it was in January even. In last few weeks, our lives really have turned upside down. We know that. And it's going to be like this for next few weeks. We don't know, few months. And the sooner we accept and sooner we try to follow all those things, the principle of personal protection, personal protective measures, making sure that social distancing principles are literally followed to the end, and environmental cleaning, we will be able to reduce the transmission of virus. So anything which your practice can do to apply those principles, that's something you have to work with your staff to how you pre-screen. I think will be a great way to reduce any chance of having infection coming to your office. Anything else, Dr. Bin, you want to add?
No, that's good. That part of our daily work can be done over the phone.
And that's why I said it, that you are a crucial partner, because you are seeing, they are asking you, they're asking your advice. So if you can do technology use is wonderful. I mean, think of that, if we didn't have technology, how would we be able to do these things? So it is actually literally at our fingertips. So please use it to the maximum ways. And then if you have a heart failure patient, I get that you can't hear the crackle. So you may want to bring them in. But if they are having cough, do you really want them bring them in? The answer will be no, because then you will say maybe they have COVID on you. Who knows? So you have to kind of triage them and put them in appropriate place. One thing which I would say, if you are going to, do not tell the patient go to the ER. That is my biggest request to all of you. Coordinate with the ER. If you think there might be some patient, at least the healthcare workers as in your office, they will be protected there too. So they can, gown up and everything and take the patient to the isolation room and make sure they do protect every healthcare worker.
Okay, great. Thanks, Dr. Gupta. Hi, what's your question for Dr. Gupta? Hello?
Hi.
Hello?
Hello, I can hear you. Can you identify yourself?
Yes, hello. This is Dr. Daryl Dykes. I'm an orthopedic surgeon and a faculty member at Upstate Orthopedics at Upstate Medical University. And I have a couple comments to make. Number one, to the individual who asked a question from the medical school perspective earlier, I appreciate your comment and your question. I'm also on the curriculum committee at the medical school, and I can assure you that we are doing everything in our power to make sure that medical students are A, safe, but then also B, given every opportunity to fulfill their educational requirements. We're working very, very closely with LCME and ACGME and all the other accrediting agencies to make sure that we are doing what we can to make sure that you get the necessary clinical exposures, but then also maintain safety for yourselves, other healthcare professionals, and of course patients in our communities. So messaging will continue to come forth from that perspective. What I'll also tell you, and I want to just sort of echo Dr. Gupta's comments with respect to preserving our emergency room resources. Whether it you like it or not, orthopedic injuries and musculoskeletal injuries are a very, very common and maybe the most common reason for patients to present to emergency departments. We have re-engineered and retooled our facilities at Upstate Orthopedics to deal with, a lot of the urgent musculoskeletal and orthopedic needs that we will continue to face, irrespective of this, COVID situation. So I would just sort of echo those responses. Please encourage your patients to reach out to you by telephone, not to overburden the emergency departments with otherwise, urgent issues. Where it's a musculoskeletal issue, we are actually poised to continue to see patients through telemedicine and urgent face-to-face consultations where it's necessary. And then we are also expanding hours for our Ortho Now, which is a urgent care, walk-in situation for urgent but not emergent musculoskeletal conditions to avoid overburdening the emergency department. So we have actually sent out messaging, which you all should receive, and in terms of how to triage and refer patients to the orthopedic facility, and again, avoid overburdening our staff and resources in the emergency department.
Thank you, Doctor. I missed your name. Could you identify? I'm sorry, I just missed.
Yeah, so my name is Dr. Daryl Dykes, D-Y-K-E-S. Okay. I'm an orthopedic surgeon and faculty member at Upstate.
Thank you so much. I think it's perfect comment in terms of, and I really appreciate you actually able to answer the medical students' question, because these are so trying time for all of us. We are being tested, all of us, and we really are in a phase where we really need to make sure we support each other and learn from each other. So, and also in terms of triaging your patient, this is the time I think the role of primary care is so important. And I'm proud to be primary care. I used to do traditional internal medicine. It is something the patient trusts you. You are, you know their voice. You know their pretty much pulse, for the lack of the word. It may sound emotional to you, but this is true. I still run into my patients and I say, we remember you and I remember them. So your role is more than anything. It's very crucial at this point. And I'm really asking all of your help to do whatever you can do to reduce the transmission of virus by making sure you are there for them, you're working with them. We work as a team. That is an important concept. It's not public health. It's not Upstate or St. Joe's or community or VA or different family care group or different medical groups. We are all in it together, and we really need to help and support each other and educate us. We need to be sharing information, and that's one of the reasons I just wanted to at least come and ask this. So thank you.
Thank you.
Okay, we have one more question. Dr. Paul Cohen, Okay, I'm sorry, Dr. Cohen, go ahead.
We can't hear you, Paul. Hello?
Can you hear me now?
Yeah, I can hear you now.
Okay, so I'm a practicing internist, and we have a small group. And first of all, I want to say that I greatly appreciate Dr. Gupta's commitment and effort and guidance in this situation, which is just unbelievably trying for her in this position, particularly in the medical society, as well as the rest of us. I have one question to Dr. Gupta. Very specifically, I would like it if you could tell us what you have learned over the past days and a few weeks about the risk of transmission of patients before they start becoming symptomatic and after they have been symptomatic, and for those who have never become symptomatic in terms of transmission of disease. It's a little bit tough to get out of the articles that I've scratched out of the literature.
Right. So it's a great question. It's a complicated question, and I will give my best first, and I'll have Dr. Wynn add to that because he's the ID and immunology background. So what we have, as you have read all these data, asymptomatic. They talk about they can transmit. Some people say they can still have transmission. How, that's kind of unclear at this point. The other thing is that how do you say that this person is not infectious now? How do you have them go back in the community? That's also do you do tests? 7 days after, should they be afebrile for so many days and then do? So it's all we are doing the best possible educated guess at this point based on the evidence coming out of other countries, especially China and and now Italy and all those places, and then CDC continues to kind of feed it to us. At the local level, which we will be very interested in looking, we are having our own looking into, that will take a little time, but that will be more of a retrospective, trying to see what we learned from our own exercise a few months when it's over. We are having our own what we call line list and trying to connect people, and it will be important for us to connect to those people at that time if we find the linkage in those individuals, and it will be at least in our own academic exercise for ourselves. At this point, what we are going from the time of onset, when the people have the first symptom, we are considering they're contagious, and that's how we put our focus on. We do the contact investigation based on that and try to pretty much follow the path of that individual where that he or she has gone, grocery store, healthcare facility, or visiting grandma, or taking care of the kids, or whatever. And then we isolate those, we quarantine those individuals and monitor those symptoms and try to have that where they might have gone if they become symptomatic. So it's an ongoing exercise. We have to see the epi curve, how it takes us, and we will learn with the time. So I would say, be more cautious. If you don't know, prevention is better than cure, right? So we were in public health preparedness mode. Overcautious is never going to be bad. I think it will be good. What bothers me the most is that when young people say, oh, it doesn't matter if you get sick, we'll be fine. But you're going to kill one of your two grandparents probably, and maybe sicken some of your friends who may have underlying problems. And these young people are not realizing it. And we are seeing that in our community when their spring breakers are coming. It's unfortunate, and it's very painful for me to see, because I'm a mother and I talk to my kids and I try to have them promote that in their social media. So they have become my voice, which I feel proud of, but they're older too, I get that. And when you're talking younger one, it's hard. And I will ask Kwok, Dr. Wynn, if you have anything else to add to Dr. Cohen's question.
Yeah.
Yeah.
I think we haven't had a complete picture of the infection. People are working, lots of labs are working on the IgG specific to this. Just to complement the PCR, had we known what is the denomination of people, let's say in China, who has IgG to this virus without having disease, then we have a good idea, good handle on how long it has been going around, and we don't know, and therefore we will know the denominator is much larger than reported. Right. And the second thing is, this PCR is a wonderful tool, but of course it doesn't not give us the true picture. For example, a recent study done prospectively on healthcare workers who took care of COVID-19 infected people, and they do serial PCR on NP of these folks, on these healthcare workers, and they found that it happened. The NP swab became positive way before the healthcare worker becomes symptomatic.
Wow. So the question is colonization, is that, how
right,
so there's a lot of complexity.
Yeah, there are lots of unknowns yet. So I think it's a great question to be able to understand the whole thing. Probably
it will take a little time.
Yeah, it will take quite a bit more.
Wow, thank you. We don't know how long they're contagious after they become clinically healed.
The problem with that is that some people who relapse too. So we don't really truly know, because the PCR is very sensitive, but it may show that very few virus, and we don't know how many virus it takes to infect a person either.
Right.
So
whenever there is so many unknowns, I think that's why the basic principle of social distancing and changing lifestyle for the time being, for the near future, is the best way to do that, because we don't have post-exposure prophylaxis. There's no antiviral, and there's no vaccine, and the only what we have is us. So
right.
I think that's the way we are trying to message, and that's what you're trying to all message. So thank you for what you do, and keep on promoting that message, please.
Thank you.
Dr. Gupta, we're closing in on 7 o'clock. Do you have time for a few more questions, or do you need to get going?
I can take one more because I have to really take care of other things. So I wish I could we can do another one maybe session when things calm down.
Great.
We are getting bombarded. So.
Well, here's a question. And this is protocol. If a staff member in a practice tests positive, what should they do?
For the office, you're talking outpatient practice, that will be applicable to inpatient. The healthcare worker has a very specific guideline, came from New York State Department of Health. I'm hoping all of our physicians or their staff is going into the healthcare commerce system, reviewing what the Commissioner Zucker sends, all these guidances. The healthcare guidance came out a few days ago, in which they had specific that people who are positive, how many days it's not in front of me right now. You have that? I think I just, I can't remember right now. But certainly there is a very specific guidance that physicians, the healthcare workers can actually work with using personal protective measures but seeing the low-risk patients. And some of that has been recommended because there is we will be so much shortage of healthcare workers. If they're asymptomatic, you're going to have everybody go into the quarantine so many days that will make it nobody's there to take care of people. It can create some controversy at times. I think people feel uncomfortable at times. But we pretty much follow the New York State Department of Health guidelines. So I think Dr. Wynn just got it. So I'm just going to read that out to you. It came on March 16th for 2020. It was sent to the hospitals. I should have gone to everybody, healthcare facilities. Because the reason was furloughing such staff could result in staff shortage that could adversely impact the operation. And they actually talked about the healthcare professional who are asymptomatic, contacts of confirmed or suspected case should self-monitor twice a day, that means temperature and symptoms, and undergo temperature monitoring and symptoms check at the beginning of each shift and at least every 12 hours. So it's like a detailed document, so I would encourage you to find that in the health commerce system. The doctor who asked that question, I think they are all in the health commerce system, they all have to be. And it came on March 16. So if you can look into that, that will be good. Otherwise, we certainly can send that out, but it's state's information comes out, and I can send it to you, Sandy. If the people can find it, we can send it.
Oh, that'd be great, Dr. Gupta. We'll get that out. Okay, thank you so much, Dr. Gupta, for your time. I think that's it for tonight. If we didn't get to your question, just email it to oncms@oncms.org, or you can call 315-424-8118, and we'll follow up with Dr. Gupta. And of course, if you want to be a member, call us, and we'll get you set up. Good night, everyone, and stay well. And thank you again, Dr. Gupta.
Thank you so much. Save the world. Continue to work with us. Thank you. Bye-bye.
Thank you.